Hi everyone, my name is Tiffany Kindratt and I am a 2020 MCCFAD research scientist. I'm also an assistant professor in the public health programs at the University of Texas at Arlington. Today I'm going to talk about my research on cognitive limitations among Middle Eastern and North African immigrants. So here's just a little bit of background. Alzheimer's disease and related dementias are often preceded by symptoms of cognitive limitations. Several studies have been conducted looking at cognitive limitations by race, ethnicity, and nativity status, particularly among non-Hispanic Black individuals, Hispanic individuals, and other minority groups besides those within the non-Hispanic white classification. So few studies have examined cognitive limitations among Middle Eastern and North African or MENA adults because they are considered white by the U.S. federal government. So the Office of Management and Budget currently exists under guidelines for the minimum classification of reporting that were passed in 1997. Individuals who were born in the Middle Eastern and North African region are classified as an example under the non-Hispanic white grouping. So in order to start to disaggregate health outcomes among these individuals, the objective of this presentation is to estimate and compare the prevalence of cognitive limitations among MENA immigrants compared to U.S. and foreign-born non-Hispanic whites from Europe, which includes individuals who reported being born in Russia or countries part of the former Soviet Union or USSR. And the second objective is to examine these differences after controlling for risk factors. So here are some inclusion criteria. The age cutoff for this study was age 65 and older, and then there are 3 regions of birth looked at. Individuals born in the United States, then individuals born in Europe, Russia, or those former USSR countries, and then individuals who reported being born in the Middle East or Africa. The study also was limited to individuals who reported having a white race as well as an ethnicity that was not Hispanic or Latino. So here are our methods. So because it is so hard to disaggregate Middle Eastern and North African individuals from that white category, we are very limited in our research using national data sources. One of the only databases that you can use to disaggregate these individuals is the National Health Interview Survey, and you can only look at foreign-born individuals born in those regions. The National Health Interview Survey was used and linked with the MEPS data source because the MEPS has a much broader assessment of some different health outcomes that are not available in the National Health Interview Survey. This includes things like medical condition data, as well as prescription data and some diabetes care and patient-provider communication variables that are of great interest to my research. So within this study, we used 2000 to 2017 National Health Interview Survey data, and there were 211,517 adults ages 65 and older who were non-Hispanic white. Then we linked those to the MEPS because the MEPS is that subset of the previous year's National Health Interview Survey data. And so we used 2001 to 2018 data, and there were 44,776 individuals aged 65 and older who were not Hispanic white. And so we linked them together, and then our final sample was 24,827 individuals ages 65 and older from these regions of birth who were also non-Hispanic white. And so this data had to be linked at a federal statistical data center. This was done at the Dallas-Fort Worth Federal Statistical Research Data Center, and it was approved prior to through the ARC, AHRQ. And so this is a picture of the Federal Reserve Bank in Dallas, which is where this research was conducted. So here are the measures. So our independent variable was measured using the data from the NHIS. So this variable combined race, ethnicity, and nativity status comparing U.S.-born non-Hispanic whites to foreign-born non-Hispanic whites from Europe, and then foreign-born individuals who were born in the Middle East or North Africa region. And then our dependent variables were from the MEPS. And so the MEPS variable on cognitive limitation was a combined measure that was created from whether or not individuals or their proxy reported yes to any of the following three questions. So whether they experience confusion or memory loss, whether they have troubles making decisions to the point that it interferes with daily activities, whether they require supervision for their own safety. So a yes response to any of these meant cognitive limitation. And so the covariates that we looked at when doing some bivariate analysis as well as in our regression models were demographics as well as potentially modifiable risk factors. The demographics we looked at were age and sex. The potentially modifiable risk factors we looked at were education, hearing loss, hypertension, obesity, smoking, depression, physical inactivity, social isolation, as measured by marital status, and diabetes. These were actually reported in the Lancet in an article by Livingston and colleagues that was published in 2017. There was later an updated edition that looked at also alcohol, traumatic brain injury, and air pollution. However, we did not include those because those data are not readily available through the MEPS. So here are some of our findings. These are the results of the bivariate analysis, and we found statistically significant differences across our groups when we looked at sex, age, hearing loss, and depression, as well as education here. So here you can see there were fewer MENA immigrants who were female. Their age was slightly lower than foreign-born non-Hispanic whites as well as U.S.-born non-Hispanic whites. The education of less than 9th grade education, 10.8%, that was actually higher than U.S.-born non-Hispanic whites, but lower than foreign-born non-Hispanic whites. There was less hearing loss reported among MENA immigrants. However, an interesting finding was that depression was definitely highest among this group. So 38.2% reported depression compared to 34.9% among foreign-born non-Hispanic whites, and then 26.7% among U.S.-born non-Hispanic whites. So then we looked at the age and sex-adjusted prevalence of cognitive limitations, and we found that it was highest among foreign-born MENA individuals at 17.3% prevalence. Among foreign-born non-Hispanic whites, it was 13.6%, and then among U.S.-born non-Hispanic whites, it was 9.6%. So here are our regression analyses. So in Model 1, our results are unadjusted. In Model 2, we adjusted for age and sex. In Model 3, we adjusted for education. And then Model 4, we adjusted for any of the potentially modifiable risk factors that fit in our regression analyses. Here you can see in Model 1, foreign-born MENA individuals had 1.75 times higher odds of reporting cognitive limitation in comparison to U.S.-born non-Hispanic whites. This increased after adjusting for age and sex to an odds ratio of 1.98, then decreased slightly after adjusting for education with an odds ratio of 1.93, and then decreased slightly again after adjusting for hearing loss, hypertension, depression, social isolation, and diabetes. So in our fully adjusted model, we found that MENA immigrants had 1.88 times higher odds of reporting a cognitive limitation in comparison to U.S.-born non-Hispanic whites. So in summary, we found the prevalence of cognitive limitations was highest among MENA immigrants. MENA immigrants had higher odds of reporting a cognitive limitation in comparison to U.S.-born non-Hispanic whites, that is before and after adjusting for multiple risk factors and demographics. But really, in order to further examine cognitive health among this population, this growing older population, Policy changes are needed to identify this group that is often absent from research because they are still considered non-Hispanic whites by the U.S. federal government. So thank you for listening to my presentation. Here are my acknowledgments. I would like to acknowledge the support of MCCFAD and the National Institutes of Health, National Institute of Aging. Also acknowledge the Dallas Fort Worth Federal Statistical Research Data Center and AHRQ for allowing me to do my research. Thank you again and have a great day.